I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another podcast episode of Tell Me Where It Hurts. Today's guest is someone I've spoken to several times in other venues, but I think has got a lot to offer as far as what the new things coming down the pike are for healthcare information sharing and a lot of those types of things. However, I will say in the past, when the ONC came up with their certification processes back in the CCHIT days, struck fear in the hearts of all of us who were creating those EHR programs out there and sitting through those certifications. So it's been a long journey from meaningful use now to what we're actually getting to, which is what I would call the real meat of healthcare information exchange and getting everybody on the same page, which I've been very happy to read about. So today's guest is Jeffery Smith. He's the Deputy Director of Certification and Testing Division with the HHS Assistant Secretary for Technology Policy, ASTP, and we'll get into that in just a minute, where he oversees and implements policies related to the ONC Health IT Certification Program. He served in many other capacities other than this one, but he's been in that capacity since 2020. He's previously served as President of Public Health Policy at American Medical Informatics Association and the College of Healthcare Information Management Executives at CHIME, where he served as lead government affairs liaison to the federal agencies. He's been a congressional staff member and been related to healthcare IT and healthcare informatics for quite some time. He holds a Bachelor of Arts degree in political science from Kansas State University and a master's degree in public policy from the University of Maryland. He's published in several different venues, including the brand new HTI-1 and HTI-2 regulations. Jeff, welcome to the podcast.
Yeah, thanks, Jay. Good to be here. Love the name. I cracked up the first time I read it, and have a smile on my face now. So good to be here.
Thank you very, very much for coming and talking with us here. Like I said, you've been in this for a long time, in several different venues. Can you tell us a little bit how you got started in this particular venue of healthcare IT and policy, and why that interested you to do that?
Yeah, so, I think like a lot of folks in the industry, I was a high-tech baby. Professionally, I was born out of the EHR incentive program and meaningful use around 2009 and 2010. I've always been fairly interested at the intersection of technology and public policy, and I kind of fell into the medical side of this, the health data side of this, because I was focusing a lot on Gov 2.0 is what the term was, as described by Tim O'Reilly and others around the 2008-2009 timeframe, when a lot of stimulus was going out of the door from the Obama administration. And so I was focusing a lot at the state level and trying to catalog by way of a trade publication what states were doing. And this exposed me to a lot of what was going on at the state level in terms of health information exchanges, as well as the regional extension centers and meaningful use. And it just so happened around that time I was finishing my master's in public policy at University of Maryland, and there was a job opening that came up for this organization I had never heard of called CHIME, and they were looking to expand their policy operations and their advocacy. And so I was lucky enough to be hired by a woman named Sharon Canner, and the team at CHIME really gave me room to run and gave us as a very small operation room to kind of really dig in and get to know the agencies that were getting involved, primarily CMS and ONC. And it was a small group at that time. Obviously, over the course of the next several years, the group and number of interested parties expanded and complexity. But just this notion of leveraging technology to improve the health of individuals as well as the health of populations, really does kind of speak to why I'm in government now and have been a fan of government for quite some time, just in terms of the power of public policy and the power of being able to establish incentives to help markets grow that are otherwise somewhat not as dynamic as you would want. And so I think that was the reason I got in. And, I think having worked with excellent organizations and individuals at Chime and at AMIA really allowed me as an individual to professionally focus on a lot of different things and get exposed to a lot of different policies and activities. So I've been very fortunate to be surrounded by smart people along the way, and fortunate to find myself surrounded by smart people today.
Well, I very much agree with the fact that if interoperability and exchange of health data was ever going to work, it had to have guidelines and guidelines, as well as pathways, and put constraints on and give some type of uniform messaging to how to get things transmitted from one thing to another. And you've been instrumental in that. Turning to HTI-1, which is in play, and there are some things coming up at the end of the year for that, and some next year. And then the proposed HDI-2, which I've had the pleasure of reading all those pages, which I absolutely agree with. I think it's well-written regulations. I've said that privately, and I'll say it publicly now. What is the administration's goal with this new round of regulation? Because I've noted, TEFCA's been around for a while. Things have started to mature. And you said right before we got started, that HTI-1 kind of like an amuse-bouche, ready to get what really needs to happen. So give us a little flavor of where you're headed with this and what the ultimate goals are.
Sure. So, I think what's, kind of important to note is that when you think about HTI-1 and HTI-2, and even when you think back to the Cures Act final rule that came out in 2020, fundamentally, we're pursuing the goals that Congress gave us back in 2009 as a function of the HITECH Act, as well as the goals that were articulated in the 21st Century Cures Act. And, broadly, that means we're looking to advance interoperability in the health space, kind of broadly defined. We're looking to support access, exchange, and use of electronic health information, and we're looking to set expectations for data sharing. And so those are kind of three buckets that really do, I think, will transcend all of the regulations that ONC puts out, because that's what Congress authorized us to do. More specifically, I think there's a growing awareness that our work, which has historically focused on the healthcare delivery setting, is necessary but insufficient, given the much larger ecosystem that healthcare delivery is a participant. And so when I say kind of healthcare delivery, what does that work mean? What have we done in this space? Well, I think we can kind of boil this down to three things that we've done in healthcare delivery, and this is primarily through the prism of the ONC Health IT certification program. And that's really that we've encouraged a standards-based, solutions-agnostic ecosystem of health IT that are focused on interoperability and various interoperability use cases. So when you think about things like transitions of care, electronic prescribing, like patient portals is another good example, as well as public health reporting, these are all kind of interoperability transactions. Now, we've also focused on, I would say, baseline functionalities. And most of these were actually mandated by Congress in 2009 when we were authorized. And two of these are decision support and quality measurement. Another good example that wasn't mandated by Congress, but certainly was part of meaningful use stages 2 and 3 was clinical information reconciliation and incorporation. So that's kind of the third bucket, or the second bucket. The third bucket is really pursuing a strategy to try and align healthcare with a more modern technology stack, like the internet, really to promote access and exchange and use through FHIR-based API, standardized APIs. So, I think when you kind of think about it from that perspective, we focused in healthcare on interoperability use cases, core functionalities, baseline functionalities, and standards-based APIs. And so really, when we look at HTI2, we're trying to expand this focus in a very similar way to both public health and health insurance providers. And so I would say that that's kind of the top line thing that we're trying to do. With HTI2, there's of course a lot of additional components to it, but we're trying to cultivate an ecosystem similar to what we've done in healthcare. As you said, kind of creating these guardrails, trying to establish baseline standards, and really trying to get information move, which is clearly not moving in ways that it should be moving. And I think you look at something like prior authorization, the standards, the protocols, just from a business process perspective, have existed for a really long time. The technology to move data from one place to another in a sequence of transactions on a timeline that makes sense, that has also existed for a long time. But quite clearly, even in this scenario where money is actually a really important driver, there's not the kind of access, exchange, and use of data that one would want to see happen. So we think that this is a really important area, and I'm happy to talk more about, kind of prior authorization or public health, if that's of interest later. But so that's kind of the big piece, is really moving our focus, expanding our focus, probably better way to put it, to include those other really important actors in the broader health ecosystem, and those being, payers, insurance companies, as well as public health.
Well, let's step into HTI1 just a little bit more, because that particular set of regulations was geared at a lot of different things, but specifically looking at clinical decision support, the new LLM. I will call it a frenzy, because they're expanding like mushrooms in a damp area. They're sprouting everywhere. And there's a lot of people trying to figure out where they're going to actually place a product or a service or whatever in that whole pathway. And you and I have talked before about how transparent that can be, or should be, which is still a concern, and how you can actually look at the certification process to get that where it should be. So can you talk a little bit about that? And because I've read the regulation, I think it's well written, but it needs an explanation as to what the real purpose of transparency in the LLM world and the transparency in the more clinical decision support that's more of this content based.
Yeah, so what we did in HTI1 relative to decision support interventions was a couple things. It built on existing set of requirements, but expanded those existing set of requirements in fairly dramatic ways. I think what's really interesting about the clinical decision support certification criterion, and now what we're calling decision support interventions certification criterion, is that it's actually a really good example of how technology can promote and support, or otherwise bring attention to, a much broader policy issue and policy questions. So to compare this, perhaps, somewhat off the cuff and ham-handedly, to another certification criterion like transitions of care, ensuring that one system can send and another system can receive a clinical, a CCDA according to the CDA standard in support of a transition of care or referral. That has a very kind of, I would say, compact and just is a discrete use case, the outcomes of which are important. And you're sitting there going, okay, well, that's for longitudinal care. And that's to make sure that information can get from one place to another, and that the data and the integrity of the information remains intact, and it's computable and all that. And that makes a lot of sense. And that's a standalone certification criterion. DSI is also a standalone certification criterion, but the policy that it's trying to achieve is actually much broader in scope. And in fact, the policy that it's trying to achieve in terms of transparency is actually only a piece in a much broader, I would say, set of policies and potential actions that need to exist. But one of the primary reasons that ONC undertook this notion and undertook this effort to update our CDS criterion, which is now DSI, was because within the authorities that we've got, the value chain, the value that we can bring to the value chain is really in trying to encourage users of clinical systems, users of decision support, to have access to information that would help them make a rational and make a decision about how this decision support could impact their patients. So I think the number one thing that we tried to bring to this was transparency into the inputs that a CDS or a DSI was relying on, as well as transparency into the performance of the decision support. And so if we focus a little bit more on kind of the less on the rules-based CDS and more on the predictive side, as well as the generative AI side, a lot of what we know about these algorithms is that firms are not necessarily testing these things for fairness, and the literature bears this out. Individuals are using these tools not knowing whether they would work on their specific patients and their patient mix. There's a lot of literature that says it's really important to test these algorithms in local data, or to evaluate using a third party these algorithms, be they predictive or generative. And really what we thought is ONC can actually have a really important role, because regardless of how broader HHS policies develop, a prerequisite is to be able to understand how an algorithm was designed, developed, tested, evaluated, and should be used. And so, we thought, let's focus on the kind of information that a user might want to have to determine if it's fair, if it's appropriate, if it can be effective for their patients, and if it's safe. And so we saw that there were existing conversations already happening in industry and academia on these model nutrition cards or these nutrition labels. We saw that there's a bunch of reporting guidelines out there, but there was no consensus. And the reporting guidelines were poorly adhered to, even reporting guidelines that had support from industry and had input from academia. And so we saw this as an opportunity to try and help crystallize conversations and coalesce ideas around the kind of information that ought to be available to users, so that they know whether their algorithm, their technology is appropriate for their patient population. So that was kind of the big picture of it all. Obviously, the devil's in the details, and we're kind of working with industry to kind of help them understand exactly what the big picture is, but also, more importantly, from their perspective, what the actual requirements are and what the expectations are in order to be certified to this criterion. But again, this is one of those interesting, I think, case studies where the minutia of what's required exists at the same level as the other certification criteria within the program, but the policy impact and the fundamental reason behind it is actually much broader in scope. And so I think it will take some time for the industry to really understand if this transparency is making a difference. But I think everything that we've seen to date indicates that a lot of what's out there today, be it generative or predictive, is being deployed somewhat with blindfolds on. And there's a growing awareness, I think, but certainly I think a lot of providers are using technology off the shelf, not really knowing and certainly not really having the apparatus to kind of pay attention post-deployment as to whether it's having the intended impact. And what we're getting from the literature are those institutions that have the knowledge and the funds and the wherewithal to take a critical look at some of these technologies. And what the literature bears out is that they're not performing as they should be performing. And so what we're trying to do is really promote high quality predictive algorithms as well as generative AI, so that these tools can actually have trust and users can have confidence in their use.
I have noticed in the literature recently that there's a lot of companies coming up with RAG analysis, your red, amber, green. So as you get the output from these systems, can you really trust it? Is it reliable? Is it not reliable? Where did it come from? So there is that even headed into the situations now, which I think is very, very interesting. So people are striving for, what can I trust? How easy is it to trust it? How easy is it to use, and things like that.
Yeah.
Stepping into the HTI2 for a minute.
Sure.
The modular API approach that you guys put in, which I think is a good one. Tell me about the certification process that EHR vendors and people who create programs in this particular industry need to think about when it comes to that particular aspect.
Okay. Yeah. So the modular API capabilities, which we include in kind of for those who are really in the soup, we include as part of our J criteria. And the creation of the modular API capabilities really came about for a couple reasons. First of all, we had plans to propose additional standardized APIs. And you see that in the public health API that we've proposed at what we call G20. And you see that in the patient, provider, and payer APIs, which exist in the federal regulation text in beginning G30 through 36. And so when we started to think about, okay, well, what does G10 need to look like? Our longstanding standardized API for patient and population services, what does that need to look like? How do we want to update that? And then we worked with our federal partners and we said, okay, we're thinking about proposing a new public health API as well as a new set of APIs for what I'll call kind of health insurance and health coverage related transactions. And really what we realized after kind of putting all the pieces on the table was that we need to kind of think about a new, more deconstructed way of establishing API-related functionalities. And not to get too deep in the weeds on the construction of all this, but I think that the API capabilities are really a combination of two things that are old and then things that are new. So some of the J criteria represent existing requirements for G10. For example, our J criteria include things like registration, authorization, and authentication. And we broke out Smart App Launch, which underpins the kind of authorization and authentication pieces, into Smart Clinician Access for EHR Launch and Smart Patient Access for standalone apps. And those historically have been part of G10, but they've been just kind of like a component piece of it. And we broke those out into separate J criteria because some APIs that we're proposing would want both of those types of launches, and some would only want one of those types of launches. And so that's a good example of something that's existed in the program, but we kind of deconstructed it and put it into the Js. We also had a set of new J criteria that were specific to new capabilities that we wanted to see in our standardized API for patient and population services. And that's something like dynamic client registration protocol and asymmetric authentication. We're trying to make a push across our APIs so that they act more consistent with our modern interactions with things like banking. Dynamic client registration is something that you would get if you download an app and you want to connect it to all of your bank accounts so that you can have a bird's eye view of your of your finance, of your spending, of your financial planning. We think the future is something similar, but with health data. And so we've heard from industry, we've heard from kind of app developers as well as developers on the certified kind of EHR side that the registration process is somewhat cumbersome. And so again, just trying to make healthcare more reflective of what's working in the consumer space is a piece of that. And then finally, the last kind of flavor of J criteria that we have are those really kind of net new capabilities that are standards like subscriptions, like CDS hooks, and like subscriptions and separately CDS hooks, as well as smart health cards. And I think we're excited about these types of things because the FHIR standard paradigm really is kind of a fundamental shift from the clinical document architecture. FHIR is a more atomic data standard. And by the way, it's a data standard, not necessarily a document standard. No disrespect to documents, but it just enables a degree of interoperability at a more granular level. And with that, it enables new types of capabilities. And I think smart health cards have been out there for a couple of years since the pandemic. CDS hooks and subscriptions have been around a little bit longer. And through our proposals in HTI2, we thought, okay, it's time to elevate these standards. They've been around for a while. And this is an interesting dynamic that we get into with standards and with regulation. But these standards have been around for a while. They're not necessarily being refined and emphasized, and the tires aren't really being kicked on subscriptions and CDS hooks at scale. But there is refinement going on. There's work going on. And so we saw HTI2 as an opportunity to really put an emphasis on these standards to encourage more widespread development and refinement of these standards, because beginning January 1st, 2028, according to our proposals, technology is going to have to support subscriptions and support smart health cards and support and CDS hooks. And so, I think this that's really kind of the idea behind the J criteria, the modular API capabilities, and I think gives you a good example of the tension that exists pretty routinely in our space, which is, should we wait for a standard to be completely fleshed out and be, agreed to that this is normative? By the way, the standards underpinning the internet aren't normative yet, but that's a different story. Or can we use this opportunity to try and kind of put a spotlight and focus the standard development community's attention on specific things? And we've chosen the latter path to try and say, hey, there's a lot of cool stuff going on at HL7 and elsewhere, IHE. These are going to be some things we think are pretty fundamental to the future, and we know they don't work incredibly well right now, but that's why we're going to give folks a couple of years, and we're going to hopefully go through a few ballot cycles, and hopefully it'll focus the collective mind's eye on these types of interactions and standards.
Let's switch the conversation a little bit to public health. One of the things that I've experienced in my practice in physician lifetime is that public health for a very long time has been disconnected. And when I mean disconnected, you've got a county public health, you've got a state public health, you've got a regional public health, and then you have the CDC, which never really worked very well. Even some registries are now just sort of coming into their own to make sure that the information is accurate and easily gotten. But in HDI2, with CDC, they're modernizing. And I think the pandemic taught us that we've got to be able to communicate rapidly things like public health threats. COVID-19 is a perfect example of that. So can you talk a little bit about the CDC modernization and trying to get that playing field all on the same pitch?
Yeah. So, obviously, as you mentioned, COVID put a glaring emphasis on the deficiencies within the space between healthcare delivery and public health. And, those glaring challenges have been there for a long time. We just didn't have something like a global pandemic to put acute pressure on those deficiencies, and essentially it really laid bare some of the problems and challenges that the system as a whole has suffered, mostly because we think culturally about healthcare delivery and public health as being distinct and being separate and being, something that has to happen here and now versus something that can happen over the course of time and at kind of a more leisurely pace. So over the, as we look back at COVID and the lessons learned started to come out, there was a lot of emphasis on this notion of a data modernization initiative. So the CDC's data modernization initiative, or the DMI, as it's called kind of colloquially, is really an articulation of how the CDC intends to try and facilitate the interconnections that need to exist from all of those levels that you mentioned, Jay. And I think that the real challenge is that the layers that exist for a reason, and many of those exist because Congress delegated authority to the states to perform public health and to essentially execute on public health, because they didn't reserve that, the Constitution didn't reserve that power for Congress and the federal government. So it was kind of de facto delegated to the states, and so of course states go in different directions based on their own prioritizations and needs, and so that really has created the fractured state of things. Now, back in 2022, though, there was a advisory committee, what we call the HITAC, and they, along with the CDC's advisory committee to the director, actually recommended that certification that has existed in healthcare for EHRs be applied to data systems for public health, because this could help address some core problems and data infrastructure and exchange needs. I think there was a shared consensus across a broad swath of experts when it comes to the HITAC and the ACD. And they really emphasize the need to develop a standards-based certification program to improve the availability and interoperability of important health information. So that was kind of the backdrop that we were working with in 2002 and began thinking through in 2003. And, I think in practice, what this means is that, between ONC and CDC, we're taking tangible steps to improve the flow of data between care providers and public health authorities. And this will just be better for patients and better for population health, kind of broadly. But I think the other really important thing for health systems to think about is, at least from our perspective, what we're attempting to do is to remove implementation barriers. So get rid of these one-off interfaces and try and create a system where clinical data can be generated and then accessed for authorized purposes, but can be accessed and information can go when and where it needs to, be it at the county level, the state level, or the federal level. We think that this can have tremendous impact and really importantly, eliminate a lot of burden that exists to report to public health. And then the third thing is really to just improve bidirectional exchange. So a lot of the information that gets generated by public health, if we can get that information back to the clinical care setting more quickly, more accurately, more consistently, that's going to have a noticeably large impact on just the care for individuals within a healthcare setting. So there's a lot of aspiration in what we're trying to do. I wouldn't downplay at all the enormity of the task, just given, I think, the notion of the geographic spread, I would say the cultural spread that exists. I think we have to operate within the confines of the political, cultural, and financial worlds that everybody finds themselves. And, part of that challenge is recognizing that various states are going to be in a better or comparatively worse position, regardless of what the certification program can do. So, I think there's a lot of important conversations that will have to happen, but we think, again, in thinking through what we can do here and now, this is something that we think can have an important impact. And, it will be an important first step in a direction towards better health for everyone, regardless of where they live.
I absolutely believe it's a step in the right direction. One of the biggest banes of my existence as a clinician was to not have, just accurate immunizations,
Yep.
Things like simple things. It's not rocket science, it's simple things. I think it's a great step in the right direction. Do you want to talk a little bit about the new rule that you just popped out?
Yeah, absolutely. So we're looking to do a couple things. At the really high level, we're looking to update a bunch of certification criteria that exist today. Those are for things like immunization reporting, case reporting, syndromic surveillance, lab reporting, cancer reporting, and healthcare surveys, I think, are among those. A lot of those certification criteria either don't have standards or are reliant or certified against standards that are several years old. And we know that additional updates and ballots have been done to those use cases. And so we're looking to really just kind of move the baseline up on a lot of those existing certification criteria. But then we're also proposing a host of corollary certification criteria for data systems that would be used by public health authorities. And so the big picture here is certifying the pitching and the catching. And I think if you kind of remember the days, this is fairly early on when we were still kind of having conversations around CCD versus CCR versus CCDA, and then what became the CCDA. We had just a single criterion for transitions of care, basically. And we didn't test on the sending or we didn't test on the receiving. We said, can you generate a document consistent with the standard? Oh, you can? Great, you're good to go. But we never really tested, in the early days, test the sending and the receiving. And that created a lot of challenge, just in terms of having documents being able to be received and sent in ways that would, essentially not cause a bunch of interoperability challenges, which we had and still do. Not to downplay any of the challenges we have today, but in public health, we've got a similar dynamic to the early days where systems are certified to send information according to a standard, but the receiving systems are in no way certified, can be built by bespoke entities for bespoke amounts of money. And what we're trying to do is create a dynamic where both the senders and the catchers are certified and certified according to specific standards. We think that will have a noticeable impact on the consistency with which information is sent and received, as well as make the job of making sense of those data once received easier. Because a lot of what public health has to deal with today is they get a document, but their systems can't really parse and filter the information in ways that make it easy to use. And so really all of those use cases I rattled off, like immunizations and syndromic and labs, we're proposing that certification criteria be established for systems that would essentially receive that information rather than send that information. And then we're working with our colleagues on the CDC side to figure out, okay, if CMS has reimbursement policies to encourage the adoption and use of certified technology in the healthcare space, what levers, what funding or incentives does CDC have to encourage grantees and states to adopt and use certified technology?
Interestingly, you said that because this particular set of regulations was the first time that I have read the word, or had the word used, usability, actually start to run into the regulations. And that has been, at least in my mind, one of the biggest problems we've had with transmitting healthcare data anywhere. It's when you send it, great, but when you get it, what in the world are you going to do with it? And how are you going to get to that little piece that you really need in front of you to take care of the problem that you're taking care of? So really happy to see that word starting to creep into some of this regulation. We're kind of coming up on the end of our time here, and I asked this question of everyone. If you had a magic wand, you were put in charge of everything, and could make one thing happen in the world of healthcare IT, what would that be?
So I've got two answers for you. One is a very nerdy, almost it's reflective of my background and history and professional experience. And then I've got another one that's a little bit bigger picture. I think if I had a magic wand, that wand would spit out money, but it would spit out money for a very specific thing. And that specific thing would be for standards development and refinement and testing and further refinement. I think nothing works in my world unless there's a standard that you can give to two different, completely non-affiliated entities who are building computers. And those individuals can look at the instructions and build their software according to a specification. That is how information gets from one place to another. I have read recently some interesting research that tries to use large language models to take clinical notes and turn it into fire. I am super excited about that, but I think we are a very long way from AI negating the use of or the need for standards. In fact, I think what that research tells us is that AI could be really helpful for taking very unstructured information and putting it into standards, so then it could be used. So I look at that and say, you know what, if we can get Congress to somehow pay attention to the need to fund standards in healthcare, that would go a long way, because we're constantly challenged by both the ability and the capacity of our standards development community to churn out high quality, good standards that can be built and iterated over time. And I think it remains one of those areas that if I had just a targeted amount of money for that on a year-over-year basis, we could actually do a lot of really important, cool things. I think at a much bigger level, being in the technology space for the last almost 15 years now, and thinking about the health broadly through a policy lens, the thing that I pretty consistently worry about is widening the disparities between those that can purchase and use the technology versus those who can't. And in some ways, technology can be an accelerant to disparities. And I worry greatly about the advent of increasingly more impressive and powerful technology, and what that could do to those who aren't able to harness that power, either because they can't afford to buy it, or they've got it and they can't afford to figure out exactly how to use it. And given what we know about the incredible power of these technologies, we're no longer talking about limiting the negative impacts to a minor amount of patients. We can have real damage at scale. And again, this comes from an optimist and a supporter, not somebody who thinks that AI is bad, but just kind of being clear-eyed about it. So one thing I would do with a magic wand, again, comes down to trying to increase and level the playing field for those parts of the country and those practitioners who just don't have the resources that they need to be successful. And so, as somebody that focuses a lot on technology, I worry about the disparities that we produce, and would love to figure out a way to address that very pernicious problem.
I couldn't agree more. So, Jeff, if someone wants to get a hold of you to ask questions or give input, how would they do that?
Yeah, so healthit.gov is not changing, at least as far as I know, even though we are now kind of the Assistant Secretary for Technology Policy / Office of the National Coordinator for Health Information Technology. We're keeping the ONC name because that's in statute. That's in what Congress told us to be called. So we will continue to answer to ONC. But healthit.gov is where you can find everything related to what we've all been talking about this hour. And I would say from there, you can go anywhere else. But if you wanted to go to healthit.gov/HTI2, that'll take you to a bunch of resources that we've got. We've got a public comment period that is open through, I think, October 4th. So 11:59, October 4. You can get your comments in on all of our proposals related to HTI2. And I would say, please, give us your comments and your thoughts. Don't worry about addressing the entire rule. Focus on the rule, pieces of the rule that you really care about. And also tell us what you like in addition to what you don't like, because sometimes people kind of take for granted the things that they kind of support, and they'll go, no, that's good, but they don't actually say anything to us. And then 6 people say they don't like it, but nobody said that they do like it. And that makes the task of moving forward with it a little bit more challenging. So if you put forward comments, please, tell us broadly what you like, and also please tell us what you don't like and how we can think about fixing it or amending it or changing it. So I'll leave it there for now.
Jeff, thank you so much for being on the podcast today.
This has been a pleasure. Thank you, Jay.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp Systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.